Good evening. Good evening, everyone. Welcome to the second Ethics of Caring seminar hosted by the Community Memorial Health Systems. Now, I have a question. How many of you were here? Can we turn the lights up for one quick sec? How many of you were here for our first session 3 weeks ago? Wow, excellent. That's wonderful. Well, thank you. Welcome back. And thank you for your continued support and interest in this topic. Now, on a belated, how many of you are here for the first time? You can't answer twice on both those questions. Welcome to you. Thank you all so much for coming. And we hope to provide you with an informative and stimulating evening about this hugely important topic of healthcare reform in the United States. My name is Dr. Jim Hornstein. I am the chairman of our hospital's bioethics committee, and it is truly a pleasure for me and a real honor to moderate tonight's community forum. Now, I don't know about you, but I find a lot about Obamacare and the entire topic of meaningful healthcare reform quite confusing. I won't ask to turn the lights on, but do any of you feel the same way? Any of you confused with this? Yeah, you can groan if you feel that way. So before we actually dive into some of the almost 500 different provisions of this new law, 500, let's spend a minute thinking about some of the very basic first principles. So let's actually start at the beginning with some first principles. Now, to begin with, let's look at the very name of our current health reform efforts, or Obamacare. The technical name is the Patient Protection and Affordable Care Act. Patient Protection and Affordable Care Act. Now, firstly, exactly who are we protecting patients from? And secondly, why is affordability, or let's face it, money, mentioned in almost the very first breath? Patient protection and money. Protection and money. Now, where have I seen those two concepts before? For those of you in the back, what it says is you have a doctor looking at a patient who's not that happy, and the doctor is saying, try to focus less on a cure and more on a treatment you can afford. Now, that's kind of funny, but then again, maybe it really isn't. For me, as we think about protecting patients, and let's face it, all of us in this room will be patients at some time or another, we are protecting patients from the fear of not being able to receive medical care when we need it the most, or losing medical care because of a pre-existing condition, or because we lose our job, or we lose our health care coverage. Put another way, this bill is about access to care, access for all Americans to treatments for an acute illness, for medical management to help manage chronic illnesses, and importantly, to prevention, to hopefully avoid us getting sick in the very first place. Which leads us to the next part of the ACA, or Obamacare, the affordability part, or put another way, to the money. Let's face it, in America, it takes money to buy health care access, quality, and availability. And in fact, it takes a lot, and a lot of money. Last year alone, more than 2.7 trillion with a T, dollars changed hands in health care. Almost $1 in $6 of our entire gross domestic product was spent on health care services. So with so many really important things at stake, life, death, illness, money, access, politics, fear, it's no wonder why healthcare reform is so confusing, so controversial, and in fact, so contentious. I said it last session, and I will repeat it again. We selected the subject of healthcare reform for this first inaugural talks, not because it was easy, which it is certainly not, but because it's important. For me, as a practicing doctor of over 25 years, it's important because the overall goal of healthcare reform is so critical. And it's critical for my patients, it's critical for you, it's critical for me and our families, and in fact, it's critical for all citizens to receive the right care at the right time and at an affordable right price. For me, the Affordable Care Act represents the most significant change in healthcare since the birth of Medicare and Medicaid in 1964. And think about that. That's almost 50 years ago. This is the most significant change in our field in almost 50 years. And for this experiment to be successful, we are going to need representatives from our hospitals, from our academic institutions, from the medical profession, and most importantly, from you, an informed public, to move us from where we are today, from conflict to hopefully creativity, and from crisis to compromise. So thank you all for coming here tonight, and join me in thanking the Community Memorial Health System, its Board of Trustees, and its administration for hosting tonight's community event in this very beautiful downtown facility. I'd also like to single out two very important people who were absolutely instrumental in making this Ethics of Caring series happen. Mr. Mike Ellenson, who I know is here but I can't see. Mike Ellenson is the Vice President of Marketing and Development for the Community Memorial Health System, and Mary McCormick, the Manager of Marketing. And again, she's here somewhere. They are and have been an absolute pleasure and delight to work with, and I would personally like to thank them and give them a round of applause. And now it's my great pleasure to introduce tonight's keynote speakers. Our first speaker will explain the theory and the reality of the new healthcare marketplaces, the exchanges, and the mandates, while we will turn to our second speaker to help explain what you'll actually see in those exchanges. Things such as the essential health benefits, the 4 different insurance plans, whether or not one will receive financial subsidies or will be eligible for Medi-Cal eligibility, and hopefully to provide specific advice from many of you here tonight. Following their prepared remarks, we will have time to pose questions to our speakers. So if you can think of a question while they're speaking, please write it down on the index card on your seat and pass it to one of the ushers walking around. I should say some of the questions that we will ask at the beginning were excellent questions which were asked 3 weeks ago, and hopefully we can continue that conversation. So let's begin. It's my very great pleasure to introduce our first speaker, Mr. Gary Wild. Mr. Wild is the President and CEO of Community Memorial Healthcare Systems. Mr. Wild earned his Doctor of Health Administration degree from the Medical University of South Carolina in Charleston. He also has a Master of Health Services Administration from Arizona State University in Tempe, Arizona. He obtained his Bachelor of Arts degree from Brigham Young University in Provo, Utah. In addition, Mr. Wild is a Fellow of the American College of Healthcare Executives. Ladies and gentlemen, please welcome to the podium the President and CEO of Community Memorial Health Systems, Mr. Gary Wild.
Thank you and welcome, everyone. I'm going to begin as soon as I get my slide to work. There it goes. I'm going to begin by describing what we talked about very briefly last time. We discussed the economics, the demographics, the lifestyle and variation in the United States, and access. 4 compelling reasons of why health reform was required. In essence, in one word, it was not sustainable. Costs were going up, and we didn't have a coordinated system, and it appeared that we were falling behind other countries in terms of life expectancy and so forth. Dr. Jerry McKenzie from UCLA then went into depth of what the Affordable Care Act was, gave a primer on what it was. So tonight, I'm going to start by talking about the national requirements for health insurance, and I'm going to describe a carrot and a stick. I want to first start with a carrot today. Excuse me. We receive our insurance from various sources as citizens of the United States. About half of us receive our insurance from our employers. About a third receive insurance from the federal government and the state government. Medicare, about 15%. Medicaid has now risen to that same level. And we spend about a similar amount in Medicaid as we do in Medicare. In California, it's called Medi-Cal. Then there are other programs, and we have 15%, it's higher in California, 15% of everyone living in the United States is without any insurance at all. So one of the goals of the Affordable Care Act was to control costs, but also to provide access through insurance for as many as possible. The goal, of course, would be 100%. But even the Affordable Care Act falls short of that number. So I want to talk about a change in something called the healthcare marketplace. There are three options now after the Affordable Care Act was passed and the Supreme Court sustained it, and I'll talk about that very briefly. Every state needed to consider a way that individuals and small businesses could enroll into a health product. A state could do it themselves, they could partner with the federal government, or they could have the federal government go forward and do it themselves. This is where a lot of the controversy that you've heard on the reports, that only 110,000 people so far have signed up, that the website is not responsive and so forth. California elected to do its own, and that program is working quite well under a program called Covered California. So the key dates here for the exchange in California, it began in October 1st of this year, where enrollment began, and this will continue through March 31st of 2013. The law states that if you receive your insurance through your employer, great. If you receive it through the government, that's fine too. But everyone is required, has a mandate called the individual mandate. If you don't obtain insurance through either your employer or from the government, you must obtain insurance. And we're going to talk about the mechanics of that and what it's all about and what the penalties might be. And so we started October 1st, and that'll go through March 31st, 2014. Failing to acquire insurance during that period of time would result in a fine. It's a modest fine, as we will describe a little later on. So Covered California is the entity within the state that provides this. And here's how it works. An individual or a small employer is defined by the number of employees. Fewer than 50 employees defines a small employer. So an individual or a small employer can go to the computer, just like you would buy automobile insurance or shop for home insurance with Geico or Progressive or State Farm or whatever insurance company might be. You can now go onto your computer through Covered California and do some comparative shopping and sign up for the program. The first questions that are asked deal with income or projected income for the next year for the family income. And the reason why that invasive question is needed for individuals that have moderate to low income, these individuals and families will probably qualify, and I'll give you the threshold in another slide, for Medi-Cal insurance, where they'll be offered without a cost the Medicaid benefit. Those that are from a moderate income may be given a premium tax credit. And I'll describe that in a little bit. In other words, they will have to obtain insurance but it will be subsidized by the federal government. All others of moderate to high income will have to purchase their own insurance without any subsidy from the federal government. Once that's determined, the individual is then prompted, what kind of plan do you wish? And there are 4 metals that we describe. They can opt for a bronze program, silver, and there's different levels within each of these, gold or platinum. The bronze plan is a plan that intends to reimburse an individual approximately 60% of projected health care costs in a year. That's an actuarial number. But the bronze plan would have the lowest premium, but it would be associated with the highest co-pays and the highest deductible. The platinum plan on the other end of the book of the spectrum, this intends to reimburse an individual about 90% of the projected costs actuarially that an individual would have. This would have the highest premium, but the lowest co-pays and the lowest deductible. So an individual can shop, and there are different prices for these, obviously, and then once that's selected, the individual has different plans to select from. In Ventura County, there are only 3 plans you can select. Those are Kaiser Permanente, which is an HMO plan, Anthem Blue Cross, which is a PPO plan, preferred provider plan, and Blue Shield of California. Small employers can also opt for Health Net for what is called the small employer healthcare option. So within the exchange, you cannot buy outside this. For example, Aetna or Cigna or any other plan, United Healthcare. You would be limited to these plans for individuals, these 3, and for a small employer, it would also include this plan there. There are slight variations. There are variations in the physicians that you can see, variations in the hospital that you can select, variations in price. Subtle differences, but each of these plans are comparable and quite similar in their benefits. Dr. Roby, I think, will describe the essential healthcare benefits that all the plans must comply with. So once you do that, you select a plan, you select which one, you then press the button, and you're signed up and you're issued a certificate. This prompt goes to the government, actually the IRS, and indicates that you have qualified by purchasing insurance. You have met the individual mandate. So let's talk about some of the carrots that are involved. For individuals and families, the carrots are essentially having insurance, number one, and hopefully more affordable than it otherwise would be, although that's controversial, as you have read in the paper and seen on TV. But there are tax credits and subsidies. An individual that earns $15,000 or less per year, or a family of 4 with annual income of $31,180, they will qualify for Medicaid, or Medi-Cal as we call it in the state. An individual who earns up to $45,960 per year, or a family of 4 up to $94,200, they will qualify on a sliding scale for subsidies in the form of a tax credit. And individuals who earn up to $28,960, or a family of 4, $58,875, will also qualify for some subsidies for the out-of-pocket expenses, co-pays, and deductibles. But I need to emphasize that the actual tax credits are determined annually when income tax returns are filed. An individual can decide to take the tax credits up front. For example, if an individual, based on their income or their family income, was to receive a $1,200 annual subsidy or tax credit, they could get that up front. And so their monthly premium would be discounted by $100 per month, or $1,200 for the year. But if their income is slightly higher or less, that is then trued up during the annual filing of tax returns. Okay, so these are applied. The tax credits are only available through the exchange. You can buy insurance, by the way, outside the exchange. And that would qualify, you're meeting the federal mandate, but you would not qualify for any of the subsidies. That is only available in the exchange. So the options are, again, you can apply all or part of the estimated tax credits up front, or obtain the tax credits if you qualify for them when your tax returns are filed. For the Medicaid population, it's anticipated that by 2019, 1.6 million Californians would be expected to qualify for the expanded Medi-Cal. I was told by somebody today that this number may be dated, it may be smaller than that. Additionally, it's expected that about 2.1 million Californians would qualify for some level of the subsidized care, or the so-called premium tax credits. For small businesses, a similar process works with the exchange. You'd be representing, if you're a small business owner, you'd be representing your businesses. The maximum tax credits have already started when the Affordable Care Act was passed, and for the last 3 years, the tax years 2010, actually 4 years, 2010, 11, 12, and 13, you could receive as a small business owner up to 35%. And even a tax-exempt organization could receive rebates back up to 25%. Phase 3 starts this next year, and a small employer, if they offer insurance, can receive up to a 50% premium expense or a tax credit. Again, the actual tax credits are determined by formula when the business income taxes are filed. And let me just describe this a little bit more detail. Small business tax credits are a function of the number of employees. The smaller the number of employees, the richer the potential tax benefit. The average salary of the employees, the lower the lower the average salary, the higher the potential tax credits. And finally, the percentage of premium that the employer pays. There's a trigger that the employer must pay at least 50% of the cost of the premium for any tax credits to be allotted in that year. Tax credits are determined annually when the filings are done. I am not a tax accountant, so I want you to consult with your accountant. Now, there are a lot of websites, there's a lot of help. Even the website, Covered California, describes this in more depth. But what the government is attempting to do is to provide carrots, tax credits to individuals and tax credits to small businesses. The hope is that many businesses will do that. Now, through a survey, Deloitte & Touche, one of the big 4 accounting firms, did a survey about 6 months ago, knowing what the tax credits would be in the law, but they surveyed businesses large and small. And one option for an employer is to exit, no longer provide insurance, but give employees a voucher that they could spend in the exchange themselves. While this was not scientific, it is anticipated that many small businesses may opt for that, and because it still is costly to provide that insurance. And up to 38% of California employers, large and small, the larger they are, the more likely they will continue to provide employee health benefits. The smaller they are, the less likely, but this is why the tax credits were there. Okay, I've described the carrots. Now let's talk about the sticks. I just want to do this slide just to show that there are other countries that have dealt with this. These countries over here have what we describe as a socialized medicine program. Great Britain, Canada, Spain, Italy, and so forth. These programs tax everybody that earns income within their countries, but everyone receives health care benefits, and they're virtually free to everybody in the country, but taxes pay it. This is a socialized model. These countries over here, Germany, Switzerland, Japan, France, Belgium, Latin America, the Netherlands is another example I'll talk about. These countries are market-based systems, where while there are subsidies, the individual or the business is responsible for buying insurance and shopping around. This is a free market system. This is a socialized system. We have examples of both in the United States. Medicaid and Medicare come right out of this program. And HMO care and PPO insurance, or even indemnity, come out of this program. The United States has tried to straddle both. And this creates some issues. Winston Churchill said, "You can always count on Americans to do the right thing after they've tried everything else." And some of the political and some of the economic and a lot of the stress that we're feeling is that we're trying to do two programs at once, a tax-based system and a free market system. We're the only country that is attempting to do this, and it creates some issues and problems. Those that felt that the Affordable Care Act was unconstitutional had 2 points of view. First, they said it is unconstitutional to require a citizen of the United States to purchase something that they do not wish to purchase. This would be the first example of that. And the second issue was states felt that the federal government did not have the right to impose upon them certain things. For example, the expansion of the Medicaid program. Well, in June of 2012, the Supreme Court handed down its ruling that the Affordable Care Act was, in fact, constitutional. It was a little bit of a reverse. Actually, the federal government argued that this was not a tax, it was a fee. But the Supreme Court said, no, it is not a fee, it is a tax. But because it's a tax, we overrule you on that, but because it's a tax, it is constitutional. So the individual mandate is permissible in the law. The federal government does have the right to tax, and therefore the individual mandate was upheld. States, however, could decide on their own whether to expand Medicaid services to the uninsured or not. So the focus here is really on this one, and that is the Affordable Care Act does require, and there is the stick. The individual mandate is real. Almost every other market-based country imposes a mandate for health insurance for employers, but if you get your insurance through employers, but if not, individual must purchase insurance. And these countries have a remarkably high percentage of the populace, whether there are citizens or non-citizens in the country, they have a remarkably high percentage of the population that has insurance, approaching 100%, 99% in many cases. So very, very high participation. And they have penalties. For example, the Netherlands, if you choose not to buy insurance, you will be caught, and the penalty is you have to pay 130% of the premium you attempted to avoid. Okay? So it's not too smart in the Netherlands, whether a citizen or an expatriate or a visitor, you should buy insurance. In Switzerland, a carden is similar to our states. So a state has the ability to enforce the law with approximately a 30% penalty. And they also have the ability to require you to buy insurance retroactively back to the first of the year. So these programs work. Incidentally, in Switzerland, the price of an individual for insurance per month is about 395 Swiss francs. That would be the equivalent of about $400, $405 in the United States. So the plans are not inexpensive, but they're required to do that. Now, For the United States, the Affordable Care Act also has penalties. In 2014, the penalty is the greater of $95 or 1% of one's income. It increases in 2015 to $325 or 2% of one's income, and 2016, $695 or 2.5% of income, and then thereafter, it'll be the same as 2016 plus an inflation factor, depending on the CPI inflation. The maximum penalty for a family is 300% of an individual, and the maximum penalty for a child under 18 is 50% of any description up here. Now, when you look at this, the mandate penalties, as we put them out, if somebody earned $30,000 per year, the penalty would be the greater of $95 or $300. If they earned $80,000 per year, it would be about $800 penalty. And it continues to go up. Let's go to 2016, $750 for somebody earning $30,000 and $2,000, which is not an insignificant fine. However, when you compare it against the estimated premium costs with the exchange, the penalties fall short of what the premiums are going to be. So many believe that a reasonable person who is healthy and otherwise healthy would opt to pay the penalty as opposed to the premium. Now, there's a couple of hooks in here. If an individual fails to sign up for the exchange during that enrollment period, October 1st through the end of March, they'll not be allowed, they'll have to wait the 9 months before they're eligible for that. However, they can buy insurance anyway on the open market. And there's the pre-existing condition, there are no pre-existing conditions. So this is one of the controversies or criticisms of the law that may be adjusted in the future. Well, I just want to stop right there, and I'm going to turn the time back over to Dr. Hornstein. Jim.
Boy, thank you so much, Gary. I don't know about you. I've been studying this and reading this, and I have not had a more clear, concise overview of what actually is going on with carrots and sticks than that. Gary, thank you so much. It's another great honor for me to introduce our second keynote speaker, Professor Dylan Roby. Dr. Roby is an assistant professor of health services at the UCLA Fielding School of Public Health. He is also a research scientist and director of policy and research at UCLA Center for Public Health. Professor Roby earned his PhD in public policy at the George Washington University in Washington, D.C. He received his Bachelor of Arts degree in geography with a minor in public policy from our own UCLA. His research interests include healthcare affordability, access to care for the uninsured, impacts of managed care, use of safety net providers, and the effectiveness of disease management programs. Ladies and gentlemen, please help me welcome to Ventura a fellow Bruin, Professor Dylan Roby, and his wife, Anna.
Hi, everyone. So hopefully Gary's disappointed this weekend when UCLA beats ASU. We won't fight during the panel, though. So thanks for having me, everyone. It's my pleasure to be here, and it's great to see a great audience kind of interested in the law. A lot of what we're talking about, though, is going to impact a very small sliver of the population, right? So it's important to keep in mind, out of the 37 million people we have in the state of California, you're probably looking at maybe 6 million people who might be impacted by the changes we're going to see due to the Affordable Care Act, with the expansion of Medicaid possibly representing about 2 million people who are eligible and about 1.5 million people we expect to sign up. But then also looking at the individual insurance market, we see currently where we have around 2 million people currently enrolled, and we expect to see another 2 million possibly enroll in the next 5 years or so through Covered California using those subsidies. So it still represents a major accomplishment for potentially the Obama administration related to expanding insurance coverage and improving access to care, but there has to be, we have to think about our healthcare system as a whole in terms of the sustainability of employer-based insurance, the options available to people through Medicaid, through Covered California, that are actually spending federal dollars. And so it's important to kind of stay involved and keep this in mind as we also look at the lens of who it will impact in California and whose lives it will potentially improve. So I'm going to talk a bit about more of the detail related to Dr. Wild's presentation. So I want to kind of review what the individual market will look like starting in 2014. So Dr. Wild brought up this issue of Covered California being created and the world in which we will now have where the individual market is equivalent to this new purchasing authority, this exchange that's been created through authority of the Affordable Care Act with federal grant money, and also the individual market that might live outside of the exchange, right? So outside of Covered California. And as mentioned, in Ventura County, you have Kaiser Permanente, Blue Shield, and Anthem doing business inside of the exchange, and you have any insurer that wants to offer individual market coverage doing business outside of the exchange. This isn't to say that the markets won't look very similar, right? So one of the parts of the law that's very important is that, if you set up an exchange that is designed to attract people who are previously uninsured and couldn't afford access to care and were, banished from the free market due to a pre-existing condition, and then you allow them to come in and buy coverage, then you end up with very sick, very low income, potentially people who use lots of healthcare services within that exchange. And we actually suffered from this kind of effect during a process for small businesses called PAC Advantage in California a few years ago, and that exchange went belly up and wasn't able to exist. So the federal government thought about this very carefully and said, okay, instead of just creating these exchanges to provide a home for people to buy coverage at a discounted rate if they had been denied coverage due to pre-existing condition or had health risks, we're actually going to enforce these new requirements across the entire individual market, whether you buy through the exchange or whether you buy outside of the exchange. So this guaranteed coverage that's now going to be available starting January 1st, 2014 is available wherever you buy individual market coverage and wherever you buy small group insurance coverage. The same rules will play out in the employer market, right? So if you're working in a large firm like UCLA or the county of Ventura, that firm is still going to go out and shop for coverage from private insurance plans just as they currently have. The premiums are still going to be based on the risk pool that signs up for those insurance plans. But now in the individual and small group market, we're basically giving the power to the exchange and to purchasers of those insurance plans to negotiate in the same way that an employer does, to have the same protections that an employer does. And we're now representing the risk in that individual market through community-based risk rather than individual risk, where we have individual underwriting that predicts what premium you should be paying due to your healthcare risks, due to your age, due to your pre-existing conditions. So having that kind of community-rated premium is very different than having what we currently have in the individual market. So with this guaranteed coverage comes a clause that doesn't allow any individual market insurance policy to prohibit people from signing up with a pre-existing condition. So you cannot be excluded any longer from the individual market of insurance if you have a pre-existing condition. In addition, the way premiums are priced are going to change substantially, where you can't be charged more because of a disease, you can't be charged more because of any health risks like smoking. Instead, the only way you can be charged more is the older age you are. So, but the rate of age premium is based on a 3-to-1 rating factor. Before in the individual market, it was a 6-to-1 rating factor. So if you're a 64-year-old, then you would be charged $6 for every dollar an 18-year-old would be charged. Now it changes to a 64-year-old only gets charged $3 for every $1 an 18-year-old is charged. So premiums should actually get lower for most people over the age of 55, whereas premiums should get a little bit higher for people who are under the age of 40. But that's really the only thing that California will vary in terms of premiums, except for the basics of where you're living, where you're buying care, as well as the size of the policy. So prices will vary depending on if you sign up for an HMO or PPO, depending on if you sign up for Kaiser or Blue Shield. But if you look within the Kaiser plan, you will basically only see variation based on the age you report, and then the subsidies you're allowed to buy due to your income. In addition, in this new individual market, we'll see a removal of the practice of insurance companies instituting annual benefit caps and lifetime benefit limits that have often acted as a ceiling where people would spend lots of money on their health care, and once they hit that ceiling, their coverage would give way. And that practice has been removed due to these insurance reforms. In addition, there will be a uniform cap based on federal law on out-of-pocket spending each year. So right now, if you go out on ehealthinsurance.com and try to buy a $10,000 deductible plan, it's actually possible to do that. And then you might have a $15,000 or $20,000 out-of-pocket maximum attached to that $10,000 premium deductible plan. That won't be allowed anymore because the out-of-pocket spending limit for an individual will now be $6,350 or $12,700 for a family. So the deductible can never be higher than that amount. So that protects people on the back end from lots of healthcare expenditures. And lastly, the thing that Dr. Wild spoke about before is the essential health benefits package. So currently in the state of California, if you were to buy a plan that was sold prior to the Affordable Care Act's rules going into effect, you would see no maternity coverage required. You might see no prescription drug coverage. You will definitely see no mental health and substance abuse coverage. And so the Affordable Care Act creates basically a standard benefit package that must be abided by every individual market and small group insurance company selling in these new marketplaces and outside of the new marketplaces. So the essential health benefits package are listed, the benefits are listed here with the basics, ambulatory patient services, hospital services, emergency, but the newer things are things like maternity and newborn care are now required. Pediatric services including oral and vision care are covered for kids. Mental health and substance abuse treatment and rehabilitation, prescription drugs, habilitative services, which are things like occupational health and physical therapy to return someone to their original state of health, and then of course the typical laboratory services and chronic disease management, as well as preventive and wellness services. So that's one aspect of the law that hasn't gotten a lot of attention, that not only are plans required to offer preventive services in every single state, but they also have to provide those services for free, even if you haven't hit your deductible. So there's no cost sharing, no deductible for prevention and wellness. So one wellness visit a year, colorectal cancer screenings, mammograms, those things are all covered free of charge now through the new insurance markets. So you can anticipate that, when insurance companies are told you now have to do these 4 new things versus what you used to do in the past, in addition to that, you can't necessarily save money by rejecting people or only signing up young people, that the model changes in terms of how they do business and where they're actually able to make money. So in terms of shopping in covered California, I think it's important to remember, one, that you can shop outside of covered California to your heart's content. It may be a little bit more difficult in kind of tracking down what insurance companies do what and what plans are available and the prices. As mentioned, covered California kind of looks like the Progressive website where you can see all of your options and choose one rather than going to the Blue Shield website separately, to Kaiser's website separately, et cetera. But in terms of shopping in covered California, just to get a sense, you need to know what region you live in. So there are 19 rating regions. Ventura County has their own. I believe it's Region 12. And so the prices in your region will be the same if you're buying the same plan, and it'll only vary based on age, right? But if you're shopping for coverage in the LA region, the prices for the same exact Kaiser Permanente plan could actually be different because each plan came in, and usually 5 or 6 plans bid on different regions, and Covered California chose between 2 and 5 plans to do business in those regions based on the premiums they were offering, the network they were offering, the ability for them to cover the entire county region that was available to them. So you'll see variation. In LA, you might see LA Care and Molina and Kaiser and Anthem Blue Cross and Health Net doing business in the Covered California individual market, but here in Ventura, you'll see Blue Shield, Blue Cross, and Kaiser. And the premiums in LA might be different than the premiums in Ventura, but when you're in Ventura signing up for a Blue Shield plan, the only difference in premiums will be based upon the type of policy you're signing up for, the type of family you have in terms of number of people, and the ages of the family members, and they have to stay within that 3-to-1 rating requirement. In terms of qualifications and eligibility for subsidies, they're based on what's called modified adjusted gross income. So basically this is line 37 of your 1040 form with things like alimony and IRA deductions factored in that allow you to create this what's called modified adjusted gross income rather than calculating some sort of monthly income. So it's not a net income or anything like that. It's kind of the gross income you have in a given year with a few exceptions. So this modified adjusted gross income is now going to be used to calculate whether you're eligible for Medi-Cal, whether you get those tax credits, or whether you get the cost-sharing subsidies that were mentioned before. In addition, if you're in covered California, you have to be a lawful permanent resident with a green card or a citizen. Undocumented immigrants are not allowed to sign up through covered California, even if they want to use their own money. That being said, they could sign up in the new individual market outside of covered California with no subsidies with their own money if they wanted to, because now they're protected by the same guaranteed offer of health care that everyone else is. Also, one thing to keep in mind related to the subsidies is that this is a piece of the pie that's supposed to protect people who don't have employer-based coverage, which is why I say only about 4 million people will probably be exposed to covered California through the individual market because of the fact that 19 million people in the state are getting coverage through their employer already. So there's a very important affordability test that you have to pass to cross the threshold into getting subsidies in covered California. And that is that your employer, if they offer you insurance coverage that's 9.5% of your income or less in terms of the amount the amount you pay for it for a single premium, then you are considered to have an affordable offer of health care from your job, and you are not allowed to take advantage of subsidies in covered California. So those of you who might be in a large firm, but they only offer you a specific health insurance plan that you don't like the network, you would have to figure out what's 9.5% of my wages, how much do I pay on a yearly basis for this employer-based plan if I was to just have a single coverage for myself only, not my family, and if that's higher than 9.5%, you're allowed to go get subsidies in covered California. If not, you can go buy in covered California and choose whatever you like, but you will not get subsidies to help you purchase it. So I did want to talk a bit about the plan types. So as mentioned, the metal tiers, or the precious metals as they're often called. And there are actually 5 different plans available, and one of them is not a metal unless we create a new minimum metal. And the minimum plan is the nice name for a catastrophic plan. So this is only going to be available for people under the age of 30, or if you have a financial problem where you get a hardship exemption from covered California directly. So this is a $6,350 deductible. Deductible set right at the out-of-pocket maximum level, and everything after that is covered at 100%. In addition, you get 3 free primary care visits and a free wellness visit prior to meeting that deductible. So this is a pretty good plan for somebody who's fairly young, doesn't think they're going to go to the doctor, but they might get the flu or get some sort of infection once a year, and they can have a free visit to their physician. They can get a free physical. But an important thing here is that in terms of the risk, it's very much like a bronze plan that will give you will pay for 60% of your risk, where you are responsible for about 40%. But you cannot use tax credits to purchase it. So if you're age 29 and you see a $150 minimum plan available to you, you might go shop for a bronze plan and actually see that once you factor in your income and get tax credits, the bronze plan costs $50 a month. So it's still better to buy the bronze plan instead of the minimum plan. But for people who are higher income, people who are under the age of 30, the minimum plan might make sense, depending on the pricing and where you live. The bronze plan is the next step up, so this is available for everyone. And the important thing about the bronze through platinum plans is that you can use the tax credit subsidy to buy any of these plans, but the tax credit subsidy you're entitled to is based on the second lowest silver plan available in your market. So depending, there's 6 different plans or 3 different plans selling in your market. If you look at the second cheapest plan, that's how much your tax subsidy is worth. And you can use that tax subsidy and go shop around for a bronze plan or a gold plan or platinum plan and pay the difference, right? So if you have a silver plan subsidy, you can choose to use it to buy a bronze plan, which makes the bronze plan almost free, but you're taking a $5,000 deductible instead of having the $2,000 deductible that you would get through a silver plan. So a bronze plan is at that 60% actual value, where it's contributing 60% of your overall costs versus 40% based on an actuarial calculation, has a $5,000 individual deductible, $10,000 family deductible, and these are the only plans you will see through Covered California that are offered with HSA options, health savings account options, because by federal law, they're above the $2,500 or so HSA threshold. So with an HSA, you can put pre-tax money into these funds and then leave it there and take it out when you need healthcare services. So you can actually sign up for a bronze HSA through Blue Shield or a bronze HSA through Anthem, but you cannot sign up for a silver HSA plan because the silver deductible is lower than the federal tax threshold for hitting an HSA contribution. You do have some co-payments and co-insurance, so you do get that one same free wellness visit, but you'd have to pay about $60 to $70 for your primary care and specialty visits. You'd pay $120 for urgent care, $50 for brand name prescriptions, $19 for generics, and then $300 per ER visit, and pay 30% co-insurance for things like hospitalizations. Now, it's important to keep in mind that these co-payments and deductibles are completely standardized in Covered California. Regardless of which plan you choose, it will look exactly the same. You don't have to figure out, would I rather pay a $25 deductible or a $20 deductible? A $25 copayment or a $20 copayment. They're all the same within each metal tier. Where you will see difference is if you go shopping outside of Covered California, you'll always see that the Covered California product is also sold in the individual market and it looks exactly the same. You just can't buy it with subsidies, but there might be 4 or 5 other plans that Anthem or Blue Shield or whoever sells that look slightly different, but still basically fall into the main bronze, silver, gold, platinum levels. Now, a silver plan is a 70% actuarial value plan, which is a $2,000 deductible for an individual, $4,000 for families. Again, you have a free wellness visit, but your copays are slightly less, right? Because you're paying for the lower deductible and you're paying for a little bit better cost sharing. So you're seeing $45 primary care visits, $250 ER visits, and only 20% coinsurance. So this looks a little bit more like what you might see in a basic small group plan, right? You know, lower deductible, not HSA, and fairly affordable copayments, albeit a little bit on the high side. But remember, this is what your subsidy buys you. The subsidies are designed to go buy you a silver plan, and you can use that subsidy to buy anything in the market except for that catastrophic plan if you're under the age of 30. Now, the gold plan doesn't have any deductible, and it also has the free wellness visit, but you can see that the copays go down a little bit to $30 for primary care visits, $50 for specialty, $600 for a surgery, or $600 per hospital day up to a maximum of 5 with 20% coinsurance if you're in a PPO plan. So in this case, if you're choosing a gold HMO like Kaiser, they'll have per day costs. If you're choosing the gold Blue Cross or Blue Shield plan, it'll be a 20% coinsurance. And then finally, the platinum plan, which looks more like the typical employer plan that we usually see, with a 90% actuarial value, no deductible, free wellness visits, and $20 to $40 copays, $5 generic drug copays, very limited costs for hospital days, $250 or 10% coinsurance. So the plans kind of run the gamut, right? And every single insurance company, Kaiser, Blue Cross, and Blue Shield, that offer in Covered California, they're required to offer at least one option in every one of those 4 metal tiers and minimum plan. So in terms of helping people buy coverage, the price protections of Covered California, by actively engaging in this bidding process and negotiating premiums with the insurers, provides fairly affordable premiums. I mean, if any of you have kind of looked at the Covered California website, you can use the shop and compare tool if you don't want to create an account and shop around. You'll often see fairly good premiums, and from my perspective, they were a lot lower than expected given existing individual market premiums we've seen over the years, given that we knew that insurers would now have to take everyone who wanted insurance, and they now had to abide by the new regulations around premium rating. So those price protections are helpful, so even people who don't get a subsidy may find a fairly affordable plan through Covered California without that subsidy, especially depending on their age. So it's very possible, given the low cost of most of the plans, that a 30-year-old would not get a subsidy even though they earned under the 4 times poverty level, that $46,000 a year, because of the fact that the premiums are priced at $150 a month and they never hit their premium cost sharing threshold. So these advanced premium tax credits are available for people. They're often called premium assistance by Covered California, and they're available for people of low to middle income. So that number that was just brought up of $94,200 for a family of 4 dictates the maximum income you can make to qualify for any sort of tax subsidy. Now, they are on a sliding scale, and the sliding scale goes from about 2% of your income all the way up to 9.5% of your income. And it's basically going to act as a ceiling. So if you are earning $18,000 a year, that puts you right above the Medicaid threshold, right around 1.5 times the poverty level. And that would trigger a 4% subsidy, which means that your income of $18,000 would be multiplied by 4%. So you would be responsible for paying $720 of your premium, and the federal government's tax credit would take care of the rest. So if those numbers are correct, where $3,820 is the typical single premium for a silver plan, then you would put $720 into that pool, and you get $3,100 from the federal government in the form of a tax credit. On top of that, as mentioned, there are these cost-sharing reductions that are available for people who earn up to 2.5 times poverty. So if you're in a family of 4 earning about $62,000, on top of the tax credits, you also get upgrades to your plan value. So instead of getting a 70% silver plan, you're given an enhanced 87% silver plan, which gets rid of most of your deductible, drops your co-payments down. So if you're shopping around on Covered California and you are offered an enhanced 94 plan or enhanced 87 plan, that means that your income was low enough that you're on top of that tax credit are being offered additional discounts on your deductibles and co-payments. So this is just the sense of how the tax credits and cost sharing work. Again, it's called premium assistance. Typically, it's based on the second lowest silver plan in your region. And you can see that on the sliding scale between 1 time poverty and 4 times poverty, it goes from 2% to 9.5%, but it sets this cap on your premium spending. It's not saying that it's going to contribute a certain percentage of your income to the premium itself. And then the cost sharing reduction is listed there as well, where you're offered an enhanced plan with that cost sharing reduction. And to give you an idea, the 94% actuarial value plan, that enhanced silver 94 plan, will erase your deductible, give you, $20 to $15 co-payments. You end up with a platinum plan or better because of your income. So I think there will be very individual situations and decisions that people have to make, right? So a lot of you here may not fall into this category of not offered affordable insurance by their employer, but earn enough money to qualify for Covered California tax credits. Some of you in the audience may be eligible for that Medi-Cal expansion. If you're eligible for the Medi-Cal expansion, so you're earning up to $15,800 per year as a single individual, or about $31,000 for a family of 4, you actually are not allowed to go into Covered California and buy coverage. You are required to go through Medi-Cal. I'm sorry, you're not allowed to go into Covered California and buy coverage with subsidies. If you choose to, you can go in and buy coverage through through Covered California at full price. But for somebody in that income range, that's typically somewhat unwise because you can get free care through Medi-Cal directly. In addition, children up to 250% of federal poverty level, or about $62,000 a year for a family of 4, qualify for Medi-Cal as well through our children's health insurance program. So you could have parents in a family of 4 earning $60,000 a year where they get discounts to buy health insurance through Covered California, and their 2 kids get free care or very minimal care with a small premium of $39 a month for Medi-Cal coverage. So people are eligible to buy in Covered California without subsidies as long as they're not eligible for Medi-Cal, don't have an affordable offer of health insurance through their employer, and aren't, a Medicare beneficiary, right? So this doesn't really impact anyone over the age of 65 who's in Medicare because you're precluded from buying in Covered California. And there are other aspects of the ACA that I'm sure we can touch on in question and answer around what's happening with Medicare. Now, in terms of employer-based coverage and making the decision between that and Covered California, the ACA allows for children up to the age of 26 to be added to their parents' plan at a fairly low cost as well. So you could have a child living outside of your household who's age 24 and probably could get a fairly good minimum plan, but it might be cheaper to put them on your employer-based plan, and that's still allowed under the ACA even after the Covered California opens. In addition, you may see employers making changes to what they actually offer you. So there are a lot of employers and many kind of human resources professionals are advising employers to basically provide the minimum necessary coverage. They provide a minimum plan at the highest cost possible, but to avoid employer penalties. So you may see employers start to drop hours for workers because the penalties are linked to being a 30-hour full-time worker, and if you are a 29-hour-a-week worker, your employer doesn't have to offer you coverage, even though you're allowed now to go into Covered California and get subsidies to help you buy coverage. So even though employers are going to be making these changes potentially in response to kind of game the system, you could very well see, you will see more choice for those employees who might lose employer-based coverage that has never existed before. Medi-Cal never took childless adults at the poverty level. We never had the ability to have guaranteed issue coverage for people who couldn't get employer-based coverage. So I think all in all, even though it's relatively confusing because of political needs and the ability to maintain the current system we work within, you'll see lots of improvements, at least and acting as kind of a safety net for people who previously have been held out of the system because they don't make enough money to buy insurance coverage, or they've been told they can't have insurance coverage because of pre-existing conditions or other elements. So we'll wrap up there, and we're happy to take questions during the panel. Thanks.
Thank you so much, Gary and Dylan. Everybody got all that? So if you don't mind, what I'd like to do is if there are any questions circulating out there, maybe one of the ushers can bring them up, and while we're doing that, I've got a couple of other ones to address to both Gary and Dylan about some of the issues that have come up both today and at our last meeting. So the first question is this. Last week, President Barack Obama apologized publicly for the rollout problems with the federal website, healthcare.gov, as we're all aware of, and also for some individuals who lost their insurance coverage. The question is, how will the problems at the federal level affect our experience here in California? And then also, if you wouldn't mind commenting, what might happen if the federal website, which we have all been guaranteed will be completed in the next 11 days, what happens if that actually is not completed?
See, the Sun Devil wants me to try first. So it's a complex question, Dr. Hornstein. So I think one of the issues is that the federal website isn't really impacting Covered California. It's important to note that in the federal law, in the law that created the Affordable Care Act, or that is the Affordable Care Act, the intent from the Senate was for every state to run their own exchange, and the federal government was not supposed to run exchanges for states. All states were supposed to do it on their own, because remember, we live in this republic that's supposed to be, a laboratory of democracy. States like to do their own thing, and all of a sudden, 36 states decided we don't like doing our own thing anymore. Let's let the president deal with it. So there wasn't really any funding. There wasn't, any expectation that the federal government should do this. So they were kind of thrown into the deep end with no, life jacket. So in these 36 states that are using the federal government's healthcare.gov website to sign up people through Covered California and sign up people for Medicaid, there is a concern that in order for insurance coverage to start January 1st, you have to sign up for coverage by December 15th. And this is true in California as well. So if the website is not functioning appropriately and people can't sign up by December 15th, they actually could be uninsured January 1st, and they would have to wait an extra month. So if they sign up by January 10th, they would get insurance starting February 1st and on and on. So the Affordable Care Act is designed with this idea that we're combining our individual risk pool and we're turning the federal government and state governments into these purchasers that will allow them to drive a harder bargain, will allow them to protect consumers from the abuses of insurance companies that we've become used to. And if that ability for people to sign up creates this incentive for sicker people to join these risk pools and younger people to stay out and healthier people to stay out, then we could see higher premiums year over year if younger people don't sign up and older and sicker people do sign up, because they're the only ones willing to go back to the website 18 or 19 times to sign up, and the younger person isn't willing to do that. On the second question related to kind of this issue of what happens, what impact that could have on California, it really doesn't have much of an impact because we're running our own risk pool through Covered California. And because everything is unified across the individual market, it actually, and in the federal level too, it actually doesn't matter from an insurance company and from the federal government's perspective where you sign up. If you went through Covered California or went through Blue Shield outside in the individual market, that risk pool is the same. And so having those people sign up for insurance who were previously uninsured or having younger people add into that pool is going to stabilize the insurance market regardless. Now, from the political perspective, I'm sure the president wants to show, or Peter Lee and the Covered California staff want to show that every month they have 50 more thousand new people signing up through their exchange. But all we really want is for people to become part of the individual insurance market and to become part of the small group insurance market and participate in Medi-Cal. And it doesn't matter where they come from. So whether you sign up through the website, whether you sign up through a certified insurance agent, whether you sign up through a certified enrollment counselor, whether you call the 800 number, whether you go to a county eligibility office and they sign you up, it actually doesn't matter where you go. And it'll still bolster the insurance market and make sure those premiums are stabilized in the long term.
You might only add what was said last session by Dr. Kaminsky, that if there is a prolonged delay with the national program, the website, it could call in question whether the individual mandate should be postponed, because individuals would not be able to access that, or that would be the claim. That is a possibility. That could affect Californians as well if there's a year pass, but that's all speculation. That would be the only effect that would have in California, in my judgment.
I think it's important to note that as long as you sign up in open enrollment by March 31st, then there will be no individual mandate penalty. Technically, the individual mandate, you would get a pass if you were uninsured for less than 3 months in the year. They wouldn't charge you the penalty. But just this one time, they kind of gave an exception where as long as you're insured by May 1st, because you signed up for open enrollment by March 31st, you would also not be subject to the penalty. So you could be uninsured for an entire 5 months out of 2014 and not have to pay that penalty.
Switching gears a little bit, in 1984, so looking back a few years ago, the California lawmakers passed a law requiring residents to buy car insurance, but failed at that time to regulate prices. And not surprisingly, insurance premiums for car insurance skyrocketed. The question is, what protections does the Affordable Care Act have to prevent runaway premiums now? And the corollary to that is next November, so 2014, actually 1 year from today, an initiative would place health insurance companies, so insurance companies that sell health care in California, under Proposition 103, which is the regulatory agency that actually brought down the prices of car insurance. So the question is, first of all, what protections does the ACA have or Covered California have to prevent premiums today from running away and being extremely expensive? And should we support Prop 103's initiative in the next November ballot?
Well, let me start with that. There is currently nothing that would prevent insurance companies raising rates. However, Covered California and the negotiations that Peter Lee has had a positive effect. In other words, insurance companies have sharpened their pencil because they knew that the market would be very transparent and allow it to be seen. Secondly, there is a potential in the future of rate regulation for insurance products. That is something insurance companies still fear, but if I'm correctly informed, there's nothing currently in the law that prevents insurance companies of raising their rates, but in doing so, they would have a loss of business because it's so transparent. That's what I see.
Right, yeah, so in the Affordable Care Act, there's not really protection for an insurance commissioner in a state to deny a rate increase request. What they do is they have a rate review process. So Dave Jones, the insurance commissioner and the director of Department of Managed Healthcare, can review any increase request that comes in from an insurance company, and if it's double digits, so if it's 10% or more, they are able to label it as unreasonable, and they can then forward that to the Department of Health and Human Services. So if you go on the Department of Health and Human Services website, you can see every single double-digit rate increase that's been requested back to 2011 since the ACA was signed, and you can see what the outcome was. So you can see where the insurance commissioner or DHHS pushed back and said, we don't think a 10.4% increase is feasible, but they settled on 9.5%. So there's this indirect ability to kind of politically pursue and keep transparent the process. But as mentioned, there's no rate regulation process where the insurance commissioner actually has the regulatory teeth to say, no, you cannot raise your rates this year. But Prop 103 would do that, which is a proposition led by consumer watchdog groups and folks like that. And actually, I believe the text of Prop 103 was probably written by Dave Jones when he was in the Assembly, and they just kind of took his bill and put it on the ballot. So Dave Jones has actually come out in favor of this proposition that would now give him the power to deny rate increases rather than just review them, give them this upsetting rubber stamp, and allow them to go through.
Moving to a different topic, it seems as though health insurance payers and also providers, doctors, hospitals, pharmacies, laboratories, have a significant amount of skin in the game. They are very much invested in healthcare reform. However, the questioner asked patients, it occurs to him, does not. So the question is, how does the ACA, how does this law motivate patients to care about their own health and the costs of their own care?
Well, the only provision that specifically relates to that is actually on the employer market side. So basically, employers are authorized first in a law called HIPAA in 1996, the Health Insurance Portability and Accountability Act, to provide, to allow discounts for people who participate in employer wellness programs. And nobody has ever implemented it because the regs weren't written correctly and things like that. And so the ACA actually enforced that requirement and made it very clear that employers could engage in this practice and that it was not considered discriminatory. So an employer is now allowed to vary premiums for their workers if the worker participates in a wellness program. So it doesn't mean they're actually allowed to charge more to the worker for not participating. They're allowed to give discounts to the workers who do participate, which works in very much the same way. So you could sign up for your health assessment program and an exercise program at work and potentially get a 20% reduction in premiums if your employer decides to participate. But as long as the people who are not participating are given the opportunity to participate. So if you have somebody working remotely and they're not actually able to participate in this exercise program, you can't penalize them, so you have to give them the same discount. So this does provide some ability for employers to decide they're going to incentivize wellness and better behavior at the workplace, and if you participate, you can get a discount. But there's nothing in the Covered California regulations or anything like that that would introduce the same types of incentives in the individual market.
I would add to that, Jim, that providers, hospitals, physicians are getting together, partnering with insurance plans to introduce more meaningful and workable prevention and wellness services with population health. Those plans will undoubtedly over time provide incentives through as simple as education all the way through some other perks to get people to focus on wellness, and that of course will engage the patient. But I think the whole goal is to provide a better health care delivery system, focus on prevention, so we can save money and keep people well and active. That's the underlying goals here, beyond just insuring everybody, finding ways of keeping people healthy, active, and providers, patients, insurance plans, of course the government, all will be moving toward that direction.
Another question that was asked, a very limited number of doctors and even hospitals so far have contracts in Ventura County to see patients through the California Covered Exchange. The question is, how will I know if my doctor is participating in the plan I'm interested in buying? And if not, who will I end up seeing?
I think I'll probably take that one. Right now, the three plans, Kaiser and Anthem Blue Cross and Blue Shield. For Kaiser, there is no change there. All the same physicians and hospitals that had the plan before still have that. The same thing is largely true with Anthem Blue Cross. If you're a physician, if you have Blue Cross, you'll be able to keep that same physician. Those letters have gone out now. Blue Shield is the only question mark there. Blue Shield is approaching a little bit different than Anthem and Kaiser, where they want to have some discounts by the providers, particularly on the physician side. The hospitals is going to settle out very soon. Our hospitals will probably be in that network as well. But many physicians are questioning whether they want to provide the services at a substantial discount. And the discounts they're asking for are about 30% less than what they are currently paid with Blue Shield. So that's the only one that has a question mark, and that will settle out sometime soon. So there still is a question mark on that one. For the small employer plan, health net plans to keep the same networks that they currently have. That's as of today. And if I'm asked the question in 3 weeks, I'll have another answer because it's still moving. It's still a fluid. Okay.
And so if you go on the Covered California website, you can click on preview plans once you start the shopping experience, and you can actually search for doctors. And when you search for a doctor, you can add them to your preferred list. And then when it pops up your plan choices, it'll have a green check mark if your doctors are in that plan and a red minus sign if doctors are not in that plan. So it's a fairly easy way to kind of just figure out which doctors are already in the network. However, as Gary mentioned, Blue Shield hasn't signed many contracts yet, so it's very likely there will be a doctor that is not currently on that list for Blue Shield, but will be on that list. So you'd want to check back regularly or talk to the physician themselves about whether they're participating. Now, if you end up wanting to buy individual market insurance and you want a hospital or doctor in your network that is not contracted with any of those three plans, you can still buy individual market products outside of Covered California, and they may charge you a higher premium because they have contracts with those doctors that are more expensive, but you'll still be protected by the same exact regulations and laws that protect people in Covered California, except you won't get the subsidies, you won't get the cost-sharing reductions.
Here's a question that may affect a number of people in this room or our parents. Are there provisions in the Affordable Care Act for long-term care costs, for custodial care, and for home care?
There was a provision in the law called the Class Act. So it was basically employers were going to be allowed to collect premiums from their employees, contribute for 5 years, and then there would be a $50 per day cash benefit, but that ended up getting repealed and kind of taken out during one of our many budget settlements over the past 3 years. So really, from a long-term care perspective, custodial care still isn't required by the Covered California law. It's our Covered California plans. It's still not required for employers. Medi-Cal will still be the place where people go for skilled nursing, for custodial care, and really they're the only game in town that covers it unless you sign up for a private long-term care plan. What has happened, though, is that Medicaid programs in every state will now have more authority to create home and community-based services programs, where they used to have to go on bended knee to the federal government and ask for permission through a federal Medicaid waiver to deliver care through home-based care and through more community-based care instead of institutionally in skilled nursing facilities. They now have that ability to more quickly add that to the Medi-Cal benefit package. So you'll be able to see skilled nursing, home care, and community-based care through Medi-Cal more frequently. But generally, it's not becoming a core part of the benefit package in any private plan.
We have two questions. They are slightly more political. Is it okay if we take the gloves off for a minute? Is that? It's a go for it? Okay. So there are two questions here. I didn't write them. First question is Obamacare really just a way for the younger generation and the middle class to fund health care for the poor? And the second question, which I'm lumping together in the more political sense, is why should I be forced to purchase an essential health benefit I will never use, and this was written by an individual who claims he's 60 years old, who says he has no interest in childhood vaccines, birth control, or maternity coverage, and he resents paying for it. So would you mind answering, is Obamacare just a way for the younger generation in the middle class to fund health care for the poor, and why should somebody who will never use certain essential benefits be forced to pay for them?
So I'll save Gary so he doesn't have to deal with, boycotts or anything. So, the obvious answer is if you don't want to pay for immunizations and maternity care, I don't want to pay for your, heart attack or inpatient days, right? So, young adults, although people perceive that they will not have healthcare problems and will not have diseases, it always happens, right? All of us die at one point. All of us spend lots of money on healthcare at one point in our lives. Sometimes it's accidental. And so for the young people who are asked to contribute through insurance premiums, the next time they get into a snowboarding accident, it's not the ER that's picking up the bill through uncompensated care and then passing it on to you to pay through your healthcare premiums through cost shifting. It's actually their $6,350 deductible plan that's going to cover it. And so there certainly is an element of individual responsibility in the law that doesn't necessarily allow people to just say, I don't need something currently, I don't perceive a need for something, so therefore I'm not going to buy it. And remember, this is, the individual mandate and that idea came out of conservative circles during the mid-90s as an opposition to Clinton's health reform plan. So these are all very conservative ideals around individual responsibility that we're adopting here. And so many people on the left are upset about that, but I don't think that, people who have been saying that individual responsibility is what Americans should live by can necessarily say that you then should not be contributing by taking that individual responsibility yourself because you don't perceive a need to buy health insurance. Now, in terms of the young adults paying for and middle class paying for the poor, I actually don't think that's how the income realignment works. It actually turns out to be very much like Medicare, where young adults and middle income people are paying for older people who are going to have lower premiums and possibly better federal subsidies. Now, poor people are going to receive Medi-Cal coverage potentially and more generous subsidies in covered California. But it's not that older people and middle income folks are paying for that. There are other parts of the law that are raising money for it. So one of the really important ones is that if an employer doesn't offer you affordable health coverage, they have to pay a penalty for every full-time worker. So they're paying between $2,000 and $3,000 per full-time worker as a penalty, and that's contributing to those tax credits. And so there's quite a few funding mechanisms in the law that pay for it. It's not necessarily that every young and middle income person is offsetting poor people or older people.
And Jim, I just add, we covered it quite a bit the last session, but there are so many compelling reasons why reform is necessary. Whether you like Obamacare or not, the current program is truly unaffordable in the future. Something had to be done. And anybody who would like to have transcripts or slides from the session before can see that, but this is not a political or contrived thing. There are real issues where the United States needed to do something. Whether you're on the right or left, something had to be done to rein in costs and to provide better access, all those things we talked about at the last session.
As we had last time, I now have 40 new questions added to these 60 last questions. So I'm going to pick 2 more, but I will also do something, and this is a promise, over the next several weeks, we will look at all of these questions and post on our website at Community Memorial Hospital Healthcare Systems answers to your questions, because so far what I'm reading are terrific, and I wish we had time to do this, and unless you plan on spending the next 18 hours here, I suspect we can do it in more efficient ways. So I would like to ask 2 more questions that were asked and then get to our final closing remarks. This actually is shifting again, and that is, how does the Affordable Care Act improve quality improve the quality of care in the United States healthcare system?
Maybe I can start with that one. Actually, even before the Affordable Care Act was passed, Medicare, that has regulatory responsibilities, introduced principles of value-based purchasing to focus on ways that hospitals and physicians could improve patient safety and quality. And if hospitals and providers responded to those incentives, they could get a improved reimbursement or sustain the current reimbursement. Anybody who does not pay attention to quality as its number one aim is not going to be able to afford to stay in business. So it has had a positive and dramatic effect in the last few years, and I think that's going to increase over time.
And I think, there are quite a few provisions of the law that nobody's been paying attention to, except I'm sure Gary, because of their innovation around patient safety. But there is this value-based purchasing incentive idea where any reductions in Medicare reimbursement are typically linked to bad performance on specific quality measures that the Medicare federal agency that runs Medicare is trying to encourage. So it's not just that they're going in and saying, we're going to cut you by 3%. They say, we might cut your reimbursement by 3% if you're in the bottom quartile of hospitals related to 30-day readmissions that are preventable. In addition, in the Medicare Advantage program, these are private HMOs that are getting Medicare beneficiaries and getting paid an amount by the federal government. They're now being scored based on a star rating scale that allows them to earn a 5 to 10% bonus on their reimbursement, their premiums. So there are all these kind of demonstration and pilot programs going on in Medicare to try to incentivize quality and value. But it's important to remember that, Medicare's, as you saw on the slide, about 15% of our population is in Medicare. Probably about a third of our costs are in Medicare. So there's a lot left in Medicaid and private insurance that we need to focus on in terms of quality as well. Right now, Covered California has made this decision to wait until 2015 to include quality metrics on the website because of the fact that a lot of the plans coming in don't have quality scores yet based on that network. And so Kaiser has been fighting for quality scores, and other plans have been saying, no, we don't want quality scores. So you'll probably see some attempt by Covered California as this new purchasing authority to try to incentivize quality as well, because the reason why we see quality improvement in Medicare is because they're the 800-pound gorilla in the room when it comes to reimbursement. They hold the purse strings for a lot of hospitalizations, and now Covered California can start holding those purse strings as well for the private individual market.
I'd like to ask our last question again, moving to somewhat of a positive note, and that is, how has the Affordable Care Act positively affected efforts in public health, in population health, and also in encouraging innovations in new models of healthcare delivery, such as the patient-centered medical home, accountable care organizations, and other innovations which healthcare reform has stimulated us to think about in ways that 5 years ago we never did. So would you talk about its positive effects on population health, public health, and innovations in health delivery?
So I think, as I mentioned before, Medicare has been taking on this role as kind of a quality improvement value-based purchaser. They also created what's called the Innovation Center within the Centers for Medicare and Medicaid Services. And they've been funding up to $30 million in grants to multiple organizations throughout the country to innovate. So they've been giving, grants to provider groups that got together and tried to do a fall prevention program, or provider groups that got together and tried to introduce a patient-centered medical home initiative in the Medicaid or Medicare population, with the idea that these 3-year demonstrations would provide evidence that allow us to decide 3 to 5 years from now what models of care really work, what kind of evidence can we use to make decisions about patient care. And so you'll see a lot of that through the Innovation Center. There's also an institute created by originally the stimulus package and now the Affordable Care Act called PCORI, the Patient-Centered Outcomes Research Institute, and they're funding a bunch of comparative effectiveness work to compare treatments to each other without, they're explicitly forbidden from using cost in the equation, but they can look at quality outcomes and value of the different models. And so they're able to actually provide evidence that might help us guide decision-making by physicians in the future. So there are a lot of those programs that are used to test innovative delivery models and patient-centered medical home and things like that.
Jim, I just add, as a provider in the trenches, so to speak, the Affordable Care Act and the dialogue around it has created, for the first time in our history, the compelling need for hospitals, physicians, and even insurance plans to work as a single unit to control costs. We have not had the same incentives. It's been a fee-for-service system, and the more you did, the more you were paid. And that is different fundamentally from all other systems in other countries, whether it's a market-based system or the socialized systems that we talked about earlier. So now we're working with the hospitalists. Those are physicians that work in the hospital, the emergency room physicians, our intensivists. Those are physicians who work in the ICU around the clock, primary care physicians. And we are finally getting together and answering the question, how do we reduce costs together? How do we promote quality? How are we able to take the dollars that we're going to have, which are going to be smaller than they used to be, and provide a better product? How do we avoid readmissions to the hospital? And our readmission rate is among the lowest in the country. We've really worked on this. We just got approved as a Medicare accountable care organization where physicians and the hospital are working together to find ways of keeping Medicare patients well and do so with fewer dollars, with improved patient satisfaction. And I don't think any of that would have happened without this national debate and without the law. I think we would have continued to go on as separate entities doing separate things. This is forcing us to truly act as a system. It's better scholarship. We're thinking more about how to do it rather than just doing it.
As is our custom, before we conclude tonight's session, I'd like to invite both our speakers to take a few minutes and to provide a final summary as to their thoughts on the current state of healthcare reform in our country today. So if you wouldn't mind, perhaps Dylan, would you please start at your soapbox?
Sure. So, I think one of the things we usually see with legislation is, an omnibus kind of package gets put together. It's 974 pages long, or however long it ends up being, for something very complex, and there are gaps and hiccups along the way where the way you're thinking about something doesn't end up being implemented in the right way or something like that. And what we're seeing now are some of those gaps and hiccups, right? So this idea that some people are losing their plan because it didn't meet the grandfathered provisions of the law but doesn't meet the new requirements is a fairly small problem when you look at the entire population. It represents 1% of people. However, if we had the ability to do a legislative fix, it could be dealt with very quickly. They could, engage in that type of dialogue. And unfortunately, from a political perspective, that's not possible. There's so much political unrest about the law that any possible thing that happens that looks negative or looks positive is drummed up very quickly, and one side takes ownership of it, and they kind of refuse to meet in the middle around solving some of the problems. So there's several aspects of the law around, the private plans, or these plans being canceled, around the fact that kids and spouses who are in families where the employer gets a affordable offer of employer-based health care, they are also held out of premium tax credit subsidies in the exchange. So there are these little glitches in the law that are fairly small and could be dealt with fairly easily, but as soon as you open the door to that dialogue, all of a sudden becomes a repeal and replace argument rather than fixing the little part of the law that appears to, hurt a specific group of people. So I think we really need to think about, we're at this place where the ACA is, almost in full implementation. We've been doing this for the last 4 or 5 years, and there needs to be some political discussion and compromise around the issues that can actually be fixed, rather than just, playing to our base and focusing on the repeal argument, or this is going off without a hitch and everybody should stand behind it. I think, our political system and our policy system is more nuanced than that, and unfortunately, politics often trumps the policy decision. So I encourage you to keep an open mind about not thinking that every time you hear about some problem with the ACA, it's not because the law is inherently bad. There was one provision that was stuck in that may not be working all that well, and we should actually fix it rather than saying the entire 974 pages should be torn up.
I'll just add to that to say that from my perspective, in California, that is not to say we're not talking about the rest of the country, but in California, it has gone remarkably well. The website Cover California works well. I've gone on it several times. It does not go down. It's very fast. It's easy to find things. It's easy to get information. And I think that at least this state, whether you like it or not, has done a very good job in preparing for this in anticipation. They got a head start, but we also saw the tea leaves that we had to get prepared. And so I think it's been remarkably good. I think this will result in improved levels of care for the nation and for everybody in the state. I think there will be tension for providers. Hospitals are nervous, physicians are nervous. There are some strains and stresses in our future dealing with declining reimbursements, dealing with utilization changes. I think that when that gets resolved over several years, not over several months, but over several years, we will end up with a better system and hopefully one that would be sustained. I would also completely add, and with an underscore of what Dr. Roby said about solutions. As I said last time, from the Hospital Association perspective, I'm on the California Hospital Association board and so forth. What we saw happen in Washington, we viewed it as 95% politics and 5% planning. It's not an indictment. It is a recognition that we have a very polarized, partisan legislature, and if any of these issues could be looked at with the partisan politics aside. And as I mentioned, George Washington warned us when he was president that the partisan politics would someday haunt us, and it really has. Whether you're to the right or to the left, I think it would be a better system as if individuals came together, and which is not going to happen, at least anytime soon, but with the aim of putting in good planning and better planning, fixing the things that need to be fixed. I think that we'd be much better off than we currently are. It's not a perfect program, but I think it's going to result in a better healthcare system than we could otherwise have had. That's my opinion.
Ladies and gentlemen, please again join me in thanking our two keynote speakers tonight, Mr. Gary Wild and Professor Dylan Roby, for really their expert presentation and their very thoughtful analysis. Thank you so much.
Nice job. Thank you, Brian.
Let me just close in a minute by noting the obvious. Next week is Thanksgiving, and I would like to tell you in just a minute what I'm thankful for. I'm thankful for living and practicing over the last 25 years in one of the greatest towns in America, Ventura, which I think have some of the kindest and warmest people I have ever known. I'm also thankful for being married for the last 32 years to my beautiful wife, Dana, and for my 3 wonderful children who are incredibly entertaining. And believe it or not, I'm thankful our country is finally tackling healthcare reform and the serious problems in our current medical care system. I'm not only thankful, but I'm hopeful that sometime in the not-too-distant future, the common goal of a more accessible, a more fair, and a more affordable healthcare system will become not a source, as Gary just mentioned, of politics and of us beating each other up, but rather a source of great American pride, American unity, both for our children, for ourselves, for our community, and for, frankly, this great country which we all love. Thank you all for your interest and your participation. Thank you again to our speakers. Thank you to Community Memorial Health Systems. And on behalf of the entire Bioethics Committee at Community Memorial Health Systems, we all wish you a happy and healthy holiday season. Good night.